Hi, I'm Vanessa Clifford. I'm a paediatric infectious diseases physician and microbiologist. Since 2017, I've been working as the medical lead for Lifeblood Milk. I'll be speaking today about our milk donors at Lifeblood Milk. In milk banking, donor selection is about ensuring the safety and quality of the donated milk for its intended recipients, and it's also about ensuring that prospective donors come to no harm through the experience of donation. With milk donation, we need to be really aware of the existing breastfeeding relationship between the donor mother and her own infant and ensure that we do not harm this relationship. I'll briefly talk about the Lifeblood Milk Service and why we exist and how we fit within the National Blood Service. I'll then discuss our donor recruitment processes and how we actually process donated milk at Lifeblood Milk. And then I'll discuss our recent reviews of donor selection in terms of donor demographics and donor deferrals, and finally briefly mention our longer-term research plans. So what is the need for donated breast milk, and why would a baby need donor milk? So in Australia, 26,000 babies are born prematurely each year, and they make up about 10% of all newborns. And of these, more than 4,000 are born extremely premature or underweight. The majority of preterm infants don't have access to sufficient maternal milk, at least for some parts of their admission to neonatal intensive care. This is for many reasons. Mothers who give birth to preterm infants are often recovering from their own health issues that led to the preterm birth, and mothers are unfortunately, of course, separated from their own infant due to neonatal intensive care admission. Infants are often in neonatal intensive care for many weeks or months. Preterm infants can't feed at the breast, so mothers of preterm infants need to express all the milk that's given to their baby. Preterm infants have very high nutritional requirements. They need a lot of protein and calories to grow adequately, as well as a variety of vitamins, minerals, and other micronutrients. If neonatal intensive cares don't have access to donor human milk or a donor milk bank, most preterm infants will receive infant formula at some stage during their hospital admission. And our estimates are up to 70 to 80% of infants in neonatal intensive care don't have access to sufficient maternal milk. In 1980, the World Health Organization issued a statement recommending that infants who can't receive maternal milk should receive human milk from other sources as the first option. And this was for very important reasons. Donor human milk protects very preterm infants against a severe gut disease called necrotizing enterocolitis. Necrotizing enterocolitis is an inflammatory condition that affects the gut. Infants with necrotizing enterocolitis require prolonged antibiotics, IV nutrition, and frequently need surgery to remove dead gut. This may leave them with long-term complications. Donor milk halves the risk of necrotizing enterocolitis in extremely preterm infants compared to infant formula. At the time that the Lifeblood Milk Service was launched in 2018 in Australia, there were only a small number of milk banks operating, and very few hospitals had reliable access to donor human milk. Lifeblood now services all neonatal intensive care units in Queensland, New South Wales, South Australia, and Tasmania. Lifeblood Milk is integrated with the National Blood Service and is able to benefit from many of the strengths of this service, particularly around quality and safety oversight, governance, and experience in product distribution across a wide geographical area. The service design benefited enormously from the input of an external National Clinical Advisory Board, composed of clinicians including neonatologists, lactation consultants, dietitians, and donor and recipient mothers, as well as the Australian Breastfeeding Association and Miracle Babies. Unlike other human tissues, human milk is regulated as a food in several states of Australia and in New South Wales and Brisbane, where we have our processing centres, and it's regulated under food safety legislation. I'll now briefly take you through the process of breast milk donation at Lifeblood Milk, from donor through processing to the recipient infant. So how does a milk donor donate? Our prospective donors usually self-identify as potential milk donors, or they may be identified by clinical staff in the neonatal intensive cares where we supply milk. There's information on how to donate on our website, but most of the time we're not actively seeking donors through media, as we have sufficient donors to meet the current demand for pasteurised donor human milk. Milk donors then go through preliminary and then comprehensive screening, which I'll describe in more detail in the next slides. The screening process is done by our donor coordinators, who are certified lactation consultants. Our donor coordinators will make telephone contact with prospective donors and then organise an in-person interview where they conduct screening, collect blood, provide counselling, and collect any milk for transport back to our processing centres. Our donor screening process is based on the blood donor screening model, with modifications to account for the different risk profile of milk donors and of pasteurised donor human milk, which is a processed product that has gone through pasteurisation. So the first level of screening is our high-level screening questions. These high-level screening questions are made available on our website, and they're also printed on cards that are distributed in neonatal intensive cares, or they may be asked by our donor coordinators over the telephone. They relate to conditions and activities that would result in an automatic exclusion from donating: HIV, drug use, smoking, or excess alcohol intake. Donors who answer yes to any of these questions will be ineligible, and therefore these questions can be used as a quick screening tool to avoid wasting further time and effort for both our donors and the donor coordinators. We needed to add some additional high-level screening questions to respond to the COVID-19 pandemic. Donors who pass the high-level screening questions proceed to our formal donor questionnaire. This is completed usually in person with our donor coordinators during a home visit. There have been some modifications to our practice with the COVID-19 pandemic, and sometimes the donor coordinators work through the questions with prospective donors prior to the home visit, at which time they reconfirm their responses in person. The donor questionnaire is a modified version of the blood donor questionnaire based on our review of international guidelines for milk donors, published evidence around risk from pasteurised donor human milk, as well as expert opinion. The donor signs a declaration once they've completed the questionnaire. Donors repeat relevant sections of the questionnaire, sections B and C, each time a new donation is collected. Donor responses to the questionnaire are checked against our guidelines for the selection of milk donors, which is an A to Z reference of health conditions, medication, vaccines, and risk-taking behaviours. This reference guide specifies deferrals based on responses to the donor questionnaire. A deferral means that an individual is not eligible to donate based on criteria used to protect the health and safety of both donors and product recipients. A prospective donor may be deferred at any point during the collection and testing process. The period of time a donor is deferred depends on the specific reason for deferral. Donors may be deferred permanently or for a specified time period. If donor selection questions arise, the donor coordinators consult with our Lifeblood medical officers or with our microbiologists, and the outcome of the donor questionnaire screening is recorded in our electronic donor management system. You can see that there's quite a long and growing list of acceptable and unacceptable medications and nutritional supplements. The guidelines for the selection of milk donors document is reviewed and updated annually. The guidelines for the selection of milk donors is based on a thorough literature review and risk assessment. This is an example of our risk assessment for live vaccines as they relate to pasteurised donor human milk. You can see that for some of the common live vaccines, MMR and varicella vaccine, there is little evidence that vaccine virus transmits via breast milk. In addition, these vaccine viruses are known to be inactivated by pasteurisation. Nevertheless, we currently have a 4-week deferral for donors after receipt of these live vaccines. This means that some mums may be temporarily deferred, as MMR vaccine is frequently offered as a catch-up vaccination after delivery. It should be noted that for many other medications and medical conditions, there's very little information about the risk to pasteurised donor human milk, and many of our deferrals reflect a precautionary approach. A strength of being part of the National Blood Service is that we can leverage some of the expertise in surveillance and horizon scanning for infectious diseases threats to blood and now milk. Our safety analysts draft and maintain up-to-date documents on a multitude of potential pathogens. These documents now include a risk assessment for each pathogen as it relates to human milk. The example on the screen is an excerpt from the document relating to cytomegalovirus, a common pathogen present in human milk. Sometimes we need to do additional work to make decisions about breast milk safety. At the start of the COVID-19 pandemic, we carried out experiments in collaboration with the Kirby Institute to ensure that SARS-CoV-2 was inactivated by pasteurisation. This gave us reassurance that our current approach to donor recruitment and acceptance was safe and effective. Once prospective donors pass the donor questionnaire, our donor coordinators proceed to collect blood for infectious diseases screening. These tests are run in our blood processing centres across the country. Tests are done for hepatitis B, C, HIV, syphilis and HTLV. Donors typically express in hospital whilst their baby is an inpatient or at home. They store their expressed milk either in their home freezer or a hospital freezer. The donors express into a variety of containers depending on their individual circumstance. Once donors have 5 litres of expressed milk ready for collection, our donor coordinators organise to visit the donor's home to repeat the donor screening questionnaire and to collect the frozen milk for transport back to our processing facilities. When the milk reaches our milk processing facilities in Sydney and Brisbane, the milk is held in freezers awaiting serological testing results. If the milk is cleared, it is then thawed and pooled from a single donor. We don't pool donations from multiple donors. It's then dispensed into standard milk bottles in preparation for pasteurisation. The pooling and dispensing occurs in a laminar flow cabinet to reduce potential airborne contamination. A calibrated digital pump is used to ensure accurate dispensing of precise volumes of milk into the milk bottles. The bottles of milk are sealed and pasteurised in the final packaging, preventing contamination post-pasteurisation. The donor milk then undergoes Holder pasteurisation. The bottles are placed in a large steri-feed pasteuriser with a data logger that monitors the heat cycle at 1-minute intervals, with data downloaded at the completion of each cycle. Holder pasteurisation is fairly standard for milk banks worldwide and involves holding the milk at 62.5 degrees Celsius for 30 minutes. There are a few other milk banks that use alternative pasteurisation methods. Holder pasteurisation is known to inactivate HIV and CMV, which are important pathogens that are known to transmit via breast milk. Holder pasteurisation also inactivates most bacterial pathogens. Our donor milk has a 3-month expiry date when held frozen from the date of pasteurisation. Bacteriological screening is done in a NATA-accredited food safety lab prior to release of the pasteurised donor human milk to hospitals. We have criteria for pre- and post-pasteurisation bacterial counts. These are important because the milk is generally being used for the most vulnerable, extremely preterm babies. Batches are discarded if they fail either the pre-pasteurisation or post-pasteurisation microbial testing. If a batch fails pasteurisation, and we expect that the donor will be returning to donate again, then our donor coordinators contact the donor to discuss ways that they can reduce bacterial contamination of the breast milk. This might mean more stringent cleaning of the breast milk pump, which tends to get contaminated with gram-negative organisms. It's important to know that it's normal for breast milk to contain bacteria, and our donor coordinators always reassure our donors that their own milk remains safe for their own infant. Milk is shipped to hospitals by a combination of road and air freight in validated shippers with tamper-evident tape designed to ensure product integrity and maintain temperature at -18 degrees Celsius or colder. We have agreements with all the neonatal intensive cares to which we supply that they will report back to us on any suspected adverse event related to PDHM. Over the past 2 years, we've had 7 suspected adverse events reported to us, all of which ended up eventually classified as unlikely to be related to pasteurised donor human milk. Postnatally acquired cytomegalovirus infection was the most common adverse event reported to us, and in all cases it was considered more likely due to ingestion of raw maternal milk rather than from pasteurised donor human milk, as Holder pasteurisation inactivates cytomegalovirus. We usually don't inform our donors about suspected adverse events in recipients unless it is relevant to the donor's own health or the health of their baby. So far, in our first 2 years of operations, we've collected milk from over 750 donors. 2,500 babies around Australia have been fed donor milk from Lifeblood Milk. But what about the parents of our recipient babies? Donor milk is usually intended as a temporary supplement for preterm babies until their mums can express sufficient milk to meet their needs. The aim of donor milk supplementation is to support breastfeeding. It can make a huge difference to mothers of preterm babies. There is evidence that using pasteurised donor human milk instead of formula as a supplement improves breast milk feeding rates at hospital discharge. Until recently, there was relatively little research into the psychological impact of PDHM availability for mothers of recipient infants, but recent work is showing that it has a huge benefit. So then we come to the question, why would someone choose to donate their breast milk? And how can we know which donors will return to donate milk after their first donation? It's important to note that we only ever accept milk from mothers who have a supply in excess of their own baby's needs. Mothers can donate excess milk from when their own baby is 4 weeks old until 12 months of age. We also accept milk from bereaved donors. At the moment, we're lucky that we have more donors than there is demand for donor human milk. We've recently started looking more closely at these issues through research focusing on our milk donors. We reviewed our donor selection processes after 12 months of operations and published our preliminary findings in the Journals of Paediatrics and Child Health. Overall, we were pleased that the high-level screening questions were very effective in screening out most donors who would be ineligible. 95% of prospective donors were able to donate their breast milk after commencing the formal screening process. We recently reviewed our donor selection processes in more detail at the end of 2 years of operations. This data forms part of a Master of Epidemiology research project done by Laura Thomas, who works in government relations at Lifeblood. Laura was supervised by our milk research fellow, Dr Laura Klein. During the 2-year study period, 565 participants were evaluated formally by Lifeblood Milk donor coordinators. Of those 565 participants, 514 were able to provide a donation during the 2-year study period, donating a total volume of 5,626 litres of breast milk. 61% of these donors were ongoing donors who provided more than one delivery to the service during the study period. A quarter of donors provided one-off donations, and 5% were prospective donors who had yet to provide any donation to the program but had registered and qualified. There were also 16 bereaved donors during the study period. The age range of participants on the date of their first donation ranged between 20 years and 51 years, and the mean age of participants was 32 years, with by far the majority of donors aged between 30 and 39 years. 75% of donors were located in New South Wales and 24% in South Australia, with 93% of all donors located in major cities, reflecting the collection capacity of our service. The majority of our donors, around 60%, are mothers of term infants generally recruited from the community, but a significant proportion of mothers have preterm infants. In fact, 23% were mothers of very or extremely preterm infants born at less than 32 weeks. Most donors expressed their first donation while their infant was in the first 6 weeks of life, around 55%, and expressed their final donation when their infant was older than 18 weeks, that's 44%. The relative socio-economic disadvantage of donors was determined using the socio-economic indexes for areas developed by the Australian Bureau of Statistics, which ranks areas in Australia according to relative socio-economic advantage and disadvantage. Donor quintiles of disadvantage were spread across all 5 quintiles with no clear pattern between the most to the least disadvantaged. At the moment, we don't know a lot about why mums choose to donate to Lifeblood Milk and what motivates them to keep on donating. The work done by Laura Thomas aimed to identify demographic characteristics of high-volume donors, but her analysis of these characteristics didn't identify any factors that could predict which donors would be able to donate large volumes of milk based on these characteristics. We also know from published research out of Brazil, where they have a large network of long-established milk banks, that simple motivation is not a predictor of volume of milk donation. This is quite different to the situation for blood donors. There have been a few recent qualitative studies published looking at what motivates donors to give milk, but there is still plenty of work to be done in this arena. As part of Laura Thomas's project, we also looked at donor deferrals. Interestingly, 190 of the 565 women screened during the 2-year study period were deferred from donating. There were only 9 permanent deferrals based on the guidelines for the selection of milk donors, but there were 181 temporary deferrals. Happily, her work showed that the majority of donors, 91%, who received a temporary deferral, returned to make a subsequent donation of their excess breast milk. These charts show a breakdown of reasons for donor deferral. There were a range of reasons for temporary deferral. 49% of temporary deferrals were due to medication use, and 27% were due to acute infections such as mastitis. Permanent deferrals are generally due to ongoing or chronic health issues. Our donor coordinators are aware that in counselling donors who need to be deferred, that they should be very careful not to discourage any donor from providing breast milk for their own infant. For this reason, we have written counselling scripts for some common conditions that result in donor deferral. These include use of medications, receipt of live vaccines, receipt of blood products, and excess caffeine consumption. Our donor coordinators use these scripts to support their counselling. We also have a research project in progress in collaboration with Professor Barbara Massa and Dr Mel Hyde from the University of Queensland, looking at the impact of temporary and permanent deferral on milk donors, as the last thing we want to do is have a negative impact on their psychological health or their breastfeeding relationship with their own infants. In summary, Lifeblood Milk has been lucky so far to have more prospective milk donors than we need to meet current demand for pasteurised donor human milk. We have developed a formal donor screening process, which is based on the best available evidence and is reviewed annually. This process results in about 30% of prospective donors receiving a deferral, but most of these deferrals are temporary, and the vast majority of donors return to donate again. Many of our deferrals are precautionary in nature, such as those I discussed related to live vaccines. We're working to set up and maintain a robust biovigilance process so that we may eventually be able to relax some of our more precautionary deferrals. Milk donors are different to blood donors in many ways. There's a third party involved, the donor's infant, who we also need to protect. We still have a lot to learn about our milk donors, what motivates them to donate, how we can make the donation experience pleasant and rewarding for our donors, and overall how we can support our donors and their infants in the best way possible. I have a large number of people to thank, amongst them a particular thanks to our Milk Bank Operations Manager, Christine Salfaro, and to our donor coordinators who work with our milk donors around the country every day. A huge thanks to our Research Fellow at Lifeblood Milk, Dr Laura Klein, who supervised Laura Thomas to carry out our 2-year review of Lifeblood Milk donors described in this talk. Thanks again.